Welcome back to the Curated Beauty Podcast. Today, we're going to talk about something super interesting to a lot of people. We're going to dissect, does estrogen therapy cause breast cancer? The answer is no. And I think that that's triggering to a lot of people for a lot of reasons. Mostly because you've been told by your doctor that it does in certain cases. You've been told that if you have an estrogen receptive type of a cancer, then you cannot take estrogen, which is actually so wrong. So I'm going to dive into a lot of that today. I'm going to give you resources to look at. I'm going to talk about different literature. But this podcast episode is to really change our mindset and to shift how we look at medical research and to really specifically look at it in terms of estrogen therapy and breast cancer. I will say that in this podcast, when I say estrogen, I'm referring to estradiol, which is the form of estrogen that we use in our hormone replacement therapies. We also use it in a different mode of delivery than most physicians. And I have spent all of my free time studying bioidentical hormones and regenerative therapy. I'm super passionate about it. I want to do it right. I think that we're doing a huge disservice to women in terms of their overall health, their well-being, their longevity. And we have so many missing puzzle pieces. And actually, they're not missing. They are there, and we need to spread the education. And you may think, well, if their literature is there, Jessica, then why aren't people shifting their mindset? I'll tell you why. We don't change because of money and marketing power by big pharma, whether you know that you're under the influence of it or not. The global market for cancer drugs is $222 billion annually. So, we're the only industrialized country that allows direct to consumer advertising of different things. And everyone is massively influenced by big pharma. Again, whether you want to believe it or not, they fund our conferences that we go to. They fund our food industry. It's serious. And hopefully with some of this new administration, a lot of that changes and all of that's to be seen. But looking at this from a big, broad perspective, I hope that you can take away from it, first of all, some knowledge in terms of estrogen and breast cancer. I hope that if you are a patient and you've been told that you can't be on estrogen therapy because of a family history or your age, or you can't take this form, because by the way, when people go through menopause, we give them oral estradiol for the most part because of the massive cardiovascular protective effects of that. And I can go into that a little bit too. Hopefully I don't forget, because this is super ad lib. But we also want other providers to take away the fact that we are all living with some sort of confirmation bias. We hear things. In this case, it's the Women's Health Initiative, which was incredibly flawed and has essentially been debunked. And all of that data has been reanalyzed. And when we look at it, estrogen therapy does not cause breast cancer. And in fact, estradiol is apoptotic to cancer cells, meaning that it kills cancer cells. This has so many implications for even men. So a lot of our males will transition care to us and they're taking testosterone perhaps, and then they're also given an aromatase inhibitor. And why they're given that aromatase inhibitor is because any of the testosterone that goes down a pathway and turns into estradiol, they think, oh my gosh, we have to block that so that men don't have any estrogen in their body. Well, estrogen is incredibly protective to men as well. And so we don't give aromatase inhibitors to men because then again, they are missing out on the amazing benefit of estradiol in their own bodies. Quick segue, because I just can't help it, for a lot of the women that are coming to our practice, they're eventually sending their husbands. And testosterone is one heck of an incredible drug. Why is it not used mainstream to treat cardiovascular disease? Well, because again, big pharma's running the show, and testosterone is a hormone. It's not patentable. It is very inexpensive to use, and it, for lack of a better term, really truly treats cardiovascular disease and reverses plaques in our system. So when we look at testosterone and we look at, for example, apolipoprotein A and B. So testosterone is going to decrease apolipoprotein B, which is the bad cholesterol, and it does that by lowering visceral fat. That also, is known as LDL. Testosterone also, when given transdermally, increases apolipoprotein A, which is the good type of cholesterol. When we give aromatase inhibitors, we are, first of all, actually increasing the visceral fat, which is super harmful for everything. It's bad for inflammation. It's bad for all of our plaque in our body. It's really horrible. And we can talk about that in different podcasts. But, so many people are using cholesterol medicine to lower their cholesterol when in fact, giving testosterone is going to lower that visceral fat. And actually, the longer that you're on testosterone, the more it's going to decrease that visceral fat. And then what happens with decreasing visceral fat is, again, you get the increase in the ApoA, which is essentially acting like a GLP-1 agonist, which we all know, and a lot of us love our Ozempic and things of that nature. And the ApoA is actually carrying the LDL back to the liver, and taking those cholesterol deposits and that plaque out of the vessel and bringing it back. Apoprotein B, which is decreased with testosterone therapy, it carries that apoprotein B carries the oxidized LDL cholesterol to the blood vessel wall, which is going to create damage. And so by being able to undo that, like you can get your cholesterol number down and decrease it and be in this happy range, and your doctor looks at your lab sheet and checks off, but it's still progressing disease if you're not taking the ApoB away from the blood vessel wall. So get your LDL off of your blood vessel wall over time by lowering your visceral fat by taking testosterone. Testosterone is amazing at increasing HDL, lowering LDL. But we're also then giving these aromatase inhibitors to minimize all the good things that estrogen can do in men. So it's just a really good example of how testosterone is the best drug for cardiovascular protection. How even if men are prescribed testosterone, they're usually not prescribed levels high enough. It's just really, really interesting to, when we look at aromatase inhibitors and how they're prescribed to block estrogen in both females and males, they cause erectile dysfunction in males. And again, that estradiol protection that is created by aromatization from the testosterone is really responsible for cardiovascular protection and for brain protection, and also protects against prostate cancer. So, like I said before, estrogen is incredibly apoptotic to cancer cells. So bringing it back to kind of this female realm of how estrogen does not cause breast cancer and actually how it's been used in treatments, we're just going to really dive into that. So what causes breast cancer? Well, the honest answer is we don't really know. We have, DNA mutations, we have damage that can happen. And when damage occurs to our bodies, which it's occurring all the time, and our body's repairing itself all the time, but when this damage occurs in the cells, sometimes it's left unchecked and these dysfunctional cells just keep growing and they turn into cancers. We know that we have risk modifiers like genetic ones, environmental ones. We have obviously lifestyle factors that we can improve upon, like diet and exercise. We have, minimizing radiation, not smoking, obviously. We're not living in such an age where people are smoking all the time anymore. But it's still a risk that we do see. And then obviously age. So the biggest risk for getting breast cancer is being female. We do know that males also can develop breast cancer, but obviously being female. And when you're in your 50s, for example, the risk is of developing breast cancer is 1 in 42. And when you're in your 80s, it's 1 in 26. When we look at different genetic issues, like people get really, scared about the BRCA genes. This is when you are lacking these genes, you have an increased risk for developing breast cancer. And so people get really nervous about, any sort of therapy of hormone replacement. They're doing radical mastectomies to avoid getting or developing breast cancer. So it's definitely a concern, and it's something on the forefront of women's minds all the time. It's a fear that we would develop that. So if estrogen caused breast cancer, like let's just think about this critically for a minute, we would see breast cancer rates increasing in younger women who actually have estrogen exposure all the time, let alone pregnant women where the levels are in like the 4,000s during pregnancy. And in fact, if you get pregnant less than 20 years old, you have a 70% decrease, 70% decrease in breast cancer rates. And if you get pregnant after having breast cancer, you do not have an increased risk of breast cancer recurrence at all. So you're, having breast cancer, getting pregnant afterwards in that rare case, and then we do not see an increase in breast cancer recurrence with levels up in the 4,000s. So the really sad thing is that it used to be run of the mill to recommend a termination of a pregnancy if you were a breast cancer survivor, because they feared, just by what they thought they know, that if you were to expose your body to those high levels of estrogen, that your cancer would come back. Also, we have had a standard practice in the past of offering the removal of ovaries after breast cancer, which there was no change in risk or recurrence or survival. And women also used to even undergo like adrenalectomies to stop any sort of hormone production, which is all because of misinformation that estrogen is bad for you. So even there's a Dr. Halstead who came up with the idea of a radical mastectomy, which is removing not only the breast, but lymph nodes and other tissue surrounding. And this is rarely used now for breast cancer management, but this had been going on for a very, very long time. And it was kind of thought that Halstead knew that this was not a necessary procedure. After he passed away, his colleague actually tried to show data, but people's confirmation bias just continued to keep this going as a routine procedure. The colleague knew that this was not the best route for therapy, and that it in fact did not increase people's survival rates or reoccurrence rates. And so even a modified mastectomy does not change outcomes compared to less invasive procedures or more conservative procedures. And the fact is that we're 7 times more likely to die of a heart disease, but women are just so scared of breast cancer. So, I think that it's important to dig into studies to really show where a lot of this stuff is coming from and kind of go, sequentially through the different studies and how they've evolved. Breast cancer research study, there was one comparing using DES to tamoxifen. So DES is a form of estrogen, and this was used, DES and testosterone both as hormones were used in the 1950s to the 1990s to actually treat breast cancer. So we were doing that before. And then tamoxifen came out in the 90s. And there was a study showing the comparison of DES to tamoxifen. This was before the WHI, by the way. And the DES female treatment group was 2 times likely to have a survival than the tamoxifen. But then why are we prescribing tamoxifen? Well, it's a new patentable drug. And we now know that tamoxifen actually has an increased risk of things like uterine cancer, blood clots, and we still continue to put women on that post-breast cancer instead of prescribing estradiol. And again, is the doctor being so negligent? No, it's what we're taught in school. It's what's pushed in terms of agenda. It's what makes money, and it's what keeps fueling this billions and billions of dollar industry annually in treating cancer patients. Okay, so next, there was a study released the same year as the Women's Health Initiative in 2002, which showed using estrogen to treat breast cancer. But then what happened? The WHO came out and scared everyone, and experts claimed that hormones cause breast cancer. We're still trying to dig out of this 20 years later, which is a shame, a crying shame at that. And then data alone showed that, or estrogen alone showed that there's a significant lowered risk of breast cancer when you're taking estrogen alone versus estrogen and what was in that Women's Health Initiative, Provera. Then there was a Finnish study in 2016, which there were a lot of components of that, but specifically talking about females on hormone replacement therapy and breast cancer. If there was a group, and by the way, this was a giant study. It was over 500,000 females. There were women that had never taken hormones, and they got breast cancer, and they had a 1 in 10 risk of dying. And then the women that had taken hormones for at least 5 years, they had a 1 in 20 risk of dying. So a decreased risk of death when being on hormone replacement therapy. And then there was a study kind of again going in 2017 by Maturitas. This was treatment of breast cancer with high dose estrogen. That also proves what we're talking about in terms of estrogen therapy being something that we go to. Estrogen is apoptotic to cancer cells. It is killing cancer cells, and it is just overlooked as the treatment of choice. Then there's an article in JAMA 2020. That was when it was published. It's the Association of Breast Cancer Incidence and Mortality Long Term. So this was kind of like a WHI follow-up. And it showed that on estradiol alone, 27% decrease of getting breast cancer. And there was a 40% improved survival rate on those who developed breast cancer and were on estrogen therapy. And then recently, there's 2 last studies, 2023 in the Cancers Journal, using estrogen again for breast cancer treatment, showed estrogen was way more effective at treating breast cancer than tamoxifen yet again. And then 2024, the breast cancer research treatment, there were 10 studies, I believe, greater than 14,000 women in this study. And if you were only on estrogen, you had a 23% decreased risk of getting breast cancer. So it's just really, really clear data that estrogen did not cause breast cancer. Again, our oncology industry gets in the way all the time. And like I said, estrogen's cheap. Why would the pharmaceutical companies endorse something like this? And also because estrogen's cheap and there's nobody out there marketing it from these giant platforms, where's the support going to come from in terms of changing people's minds in terms of what is working in these therapies? From my standpoint, it's going to come from practitioners who look at this data and who are really diving in and asking these difficult questions. So I will say again, the aromatase inhibitors that we're giving people, if you are using aromatase inhibitors, you have aromatase in every single organ. So you're really affecting everything, which is why it has those downstream effects that, we don't always think about. But I think that when we talk about estrogen replacement therapy in breast cancer, I hear all the time from our patients, I can't be on any sort of hormone replacement therapy because I have either a personal history of cancer or a family history of cancer. And I'm here to tell you that when you look at the data and estrogen is a treatment for, then why would you withhold your body from having something that's not only going to prevent, but also to treat? And where we know that estradiol and estrogen therapy do not cause an increased risk of breast cancer. It's just sad that there was just such a flawed study that really did a lot of damage and a lot of harm and really set a lot of women up to kind of develop these bad diseases down the road from something that was incredibly preventable by offering our body something that it's just not producing anymore. When we talk about estrogen therapy, a lot of people are either getting some sort of estrogen patch or some sort of estrogen transdermal cream, or even a compounded cream of, like, I see a lot of things. People come in on a compounded E1, E2, E3, E2 combo with maybe some progesterone or some testosterone. And really, people really raise an eyebrow around us when we talk about how we prescribe oral estradiol. And yes, in women greater than 60. So I will kind of back down and say that with synthetic forms of estrogen, which we do not prescribe, these are forms of estrogen that our body does not recognize. So these are non-bioidentical. This does hold a little bit of a risk in increased risk of strokes or blood clots. Because of that, the U.S. Preventative Task Force said, I don't recommend estrogen orally, but the risk is only for women who are greater than 63, and it is only in the first year of life, and it's barely a statistically significant data. But when we look at oral estradiol, which is the bioidentical form of estrogen given orally, there is no risk of any of those things. I repeat, no risk of blood clots, stroke, sudden cardiac death, cancer, any of those things. And there's also no risk of estrogen or estradiol causing a reoccurrence of cancer. So we only prescribe estradiol. The other thing that's really important is that people would say, well, I'm just not going to take the risk. I'll just do the transdermal. I hear what you're saying. I can buy into this a little bit. But why the oral estradiol is so important is because you want the first pass effect, because that's where you're getting the cardiovascular protection. So you may have transdermal patients minimizing their hot flashes, their night sweats, but it's not preventative for the cardiovascular disease. It's not as preventative for the osteoporosis and also for Alzheimer's dementia. There's article after article showing a lot of harm when you don't use estradiol, and now when you don't use estradiol transdermally, because we really, really need that first pass effect to show that cardiovascular protection. And that is something that we're seeing again and again. And honestly, we're putting our patients anywhere from 2 to 4 to 6 milligrams of estradiol, and we're seeing in studies that the higher the dose showed the increased protection, and that there was no plateau effect, and there was also no harmful effects. I will say that we don't prescribe estrogen to anyone who has not gone through menopause. Your body before menopause is still producing estrogen. And if you have an estrogen excess, meaning that you have too much estrogen, then you can experience the 5 B's of excess estrogen, which is bitchiness, bloating, breast tenderness, breakouts, and bleeding. So if you have any side effects of too much estrogen when you're on estrogen therapy, we can always stop and then go down to every other day and really work yourself up to that ideal dose. But, it's very interesting because even commercially available, like even if we can get doctors on board, and the ones that still talk about compounding pharmacies not being the best. So there is a 2 milligram commercially available estradiol tablet, and 10% of women get breast tenderness. But 1 milligram isn't enough. And so that's why the beauty of what we do a 1.5 milligram oral capsule, and then we increase it as needed, but we need to compound this. And that's honestly what works best, that we're driving all the protection from this first pass effect. When we have sublingual or creams or patches or pellets or vaginal, these are not giving you that first pass effect. And so it's really, really important to know all of these kinds of things when you're being prescribed hormones. They're not all equal. I will make one more little caveat with estradiol therapy. So it's really common practice, because new studies have demonstrated that we must be using estradiol in conjunction with progesterone, which I fully agree. For many, many reasons, progesterone is so good for your body, for your brain, for balancing out the estrogen, for just so many things. We could do a different podcast on progesterone. But what a lot of times will happen with doctors who are not in the know of how we replace these hormones is they are giving progestins, and progestins are not progesterone. They actually have almost the opposite effect of progesterone. They are synthetic forms, and it is very, very important that when we are using estradiol, we are also using a synthetic form of progesterone. So we're not using these conjugated equine estrogens and progestins. That is not what we're doing. But if you are also using progesterone bioidentical forms, it's also going to give you a decrease in breast cancer risk. But progestins, all of them increase your breast cancer risk. So it's very important to go to someone, find someone who practices a similar way that we do. We are more than happy to take you on as a patient if you've been looking for a bioidentical hormone replacement therapy clinic. And if we're not in the location that you are, we can try to help you find someone that's in your same location, because we're really passionate about being the marketing force of getting out the correct treatments, getting out current literature, and making sure that our patients live their best lives. If you guys have any questions on things that you want us to cover, myths you want us to bust, I would really love to hear those, because it's such a sweet spot of being able to get people on hormone replacement therapy. If you're sitting there thinking, would I benefit from it? If you are a female and you're aging and you're starting to see any of the symptoms like insomnia, mood changes, weight gain that's stubborn, changes in your skin texture, changes in your vaginal tissue, like painful intercourse, if you're having any sort of irregular menstrual cycles, infertility, all of those things are a compilation of hormone disturbances. If you're cold, fatigued, and tired all the time, like that might be something going on with your thyroid, let alone your testosterone or progesterone. I see so many women just really beating themselves up, trying to do all the things right and get enough water and get enough protein and work out and try to get enough sleep. But when you're doing all of those things and you're still not maximized, I've been in your shoes where you're actually kind of gaslit when you tell your doctor what's going on, because everything on your lab levels just shows within normal limits. And it's really defeating. It's almost like you want to see something wrong, because you're like, why do I feel this way? And something that we really like to drive home is that normal is not optimal. All those lab values are showing you is old, sick people's normal ranges. We want optimal young levels so that we can feel youthful, so that we can live not only longer by putting us all on all these pharmaceutical medications. We want to live stronger lives and live without all of these comorbidities. So I am so grateful for the space, the platform to be able to share these things. I'm grateful for the ability to go to these trainings and learn the latest and greatest. And I will absolutely be doing my part to spread this wellness knowledge on a platform such as this. Again, if you guys want to get in touch with us, head to our show notes. We have our website linked, and I will also include a link for booking as a new bioidentical hormone replacement therapy patient.